Hello, my name is Daynor Kiza, Director of Risk Management at the Risk Authority-Stanford. Welcome to our live webcast, sponsored by the Risk Authority in partnership with Aon Risk Solutions and the Medical Protective Company. Thank you for joining us. Today, we'll be discussing healthcare transformation, the shift from volume to value, and specifically, finding the upside opportunities so that healthcare organizations can survive the sea of change under the Affordable Health Care Act. We know that the transition from volume to value is not an easy task, but a much needed change given that our current payment system basically rewards quantity of care and not quality of care. And since the passing of the Affordable Care Act, many healthcare leaders have been identifying strategies and solutions for improving quality of care and controlling escalating costs. Despite the challenges and the level of uncertainty, it's truly a dynamic and exciting time in healthcare. And within the next hour, we hope to stimulate discussion and thought on finding the upside opportunities. Without further ado, I'd like to introduce our three leading industry experts who will be guiding our discussion as we navigate through the sea of change and find upside opportunities. I'd like to introduce our first guest. Ron Calhoun is a national healthcare practice leader at Aon. Welcome, Ron.
Good to be here.
Our next panelist and expert is Kim Pardini-Kiley. Kim is the Vice President of the Risk Authority. Thank you for coming, Kim.
Pleasure to be here. Thank you.
And rounding out our panelists is Dr. Graham Billingham. Dr. Graham Billingham is the Chief Medical Officer at the Medical Protective Company. Glad you can join us.
Thanks for having me.
Ron, you are the National Practice Healthcare Leader, and a lot has changed. So can you give us the 35,000-foot view and tell us the current trend in healthcare?
Absolutely. I'm going to go through a couple of quick slides here. First, I'm going to address the recent growth of accountable care organizations. There are roughly 626 ACOs today, but you've seen one, you've seen one. They break out into three broad categories. About 329 of them participate only in government contracts. Roughly 210 participate in commercial contracts, and about 74 participate in both. We have 13 ACOs that are still undeclared, and actually just off the press on Tuesday, Sharp announced that they were pulling out of the Pioneer ACO status, and that makes it 10 that have done so, and some of them have declared a transition into a Medicare Shared Savings Program as opposed to a Pioneer. We've seen roughly 51% of those ACOs are physician-led, but the trend seems to be tapping out. It seems to be plateauing because of the trailblazers have already made their move. And I think another inhibiting factor of additional growth is the fact there's no preeminent model that's emerged. So we'll go to the next slide. This just simply affirms the fact that most of the growth was in 2012 for both the number of ACOs and the attributed populations. Right now we have, from a non-Medicare patient population attributed to or participating in CMS ACOs, non-Medicare patients participating in CMS ACOs, roughly 33 million. Non-Medicare patients in commercial ACOs, roughly 9 to 16 million. That number is a little hard to track because it's hard to get that information from the payers, frankly. The Medicare beneficiaries in CMS ACOs are right now about 5.3 to 4 million. So that foots to anywhere from 46 to 52 million Americans are touching accountable care organizations right now. It's projected that in 2017, that number will grow to about 130 million. Now I want to get to the slide that's on the screen. This is an interesting slide in that it talks about, what this is trying to communicate is the four primary paths that employers have to choose from. They can either migrate into the exchange, facilitate subsidies for their employees to migrate into the public exchanges. Right now that's tracking at about 26%. Employers can exit completely and pay the fine. That's tracking at about 6%. They can stay and continue to manage medical trend the way they've been managing it in the past, and that's the lowest category at 5%. And then we have this other interesting category called house money, house rules, and those are the large employers that are hunkering down in their ERISA self-funded employee benefit plans, but they're basically adopting the philosophy of, this is my money, so you're going to play by my rules. So this is where all the commercial payment transformation is coming from. Large employers that are adopting global bundles, moving towards population management, shifting risk to the payer directly or to the provider directly or through a payer. So this is, I think, what's driving, what we know, this decision from the Fortune 1000, principally the Fortune 500, and actually being driven primarily by the Fortune 100, is the fact that they are moving in this direction, house money, house rules, and really pushing the envelope as it relates to commercial payment transformation. This is probably the most important slide. So we see, if you take over the next 10 years, if you map out provider revenue over the next 10 years, what is that going to look like, and how are they going to migrate and adopt to these payment transformation models? And they're really going to fall into four broad categories. Providers are either going to be volume oriented and hanging on to fee-for-service. That's where over 50% or greater of their revenue is coming from fee-for-service contracts. And there's still vestiges of fee-for-service that will remain, principally in the South and ironically in the Northeast. We've got destination acute care providers, and those are the providers that don't have all of the ambulatory or primary care assets on the front end to be an effective population manager. So they're focusing on what they do best clinically, whether it's cardiac, whether it's OB. I know there's a large employer that does all their pelvic organ prolapse procedures at Geisinger Clinic, for example, and they actually warrant that procedure. So they'll fall into that category. The third category being population managers. Those are the entities that actually have either owned or appropriate affiliations with primary care assets, ambulatory assets, and post-acute assets to be able to effectively manage those populations. And those will be the players that roughly participate in north of 60% of their total payer mix, in the commercial segment being driven by total cost of care models. And then you have the fourth, which is really kind of the schizophrenic category, and that is those providers that are trying to live in both worlds, trying to live in the fee-for-service world while they attempt to participate in all of these other different payment transformation models that are emerging, which will be very difficult. Each one of these four categories require its own unique model, its own unique form of clinical and operational transformation. That's it.
Well, they're very interesting because you had outlined the four different categories, and it brings to mind what's really going to survive all of this. It's almost, the analogy is the healthcare Hunger Games, so to speak. Do you have any forecasting as to whether or not you see great promise in innovative contracts and different payment models?
Yeah, that's a very good question, and I think one that it's hard to peg exactly how those four categories are going to be distributed. You know, how is that distribution going to pan out? And I think it's those, and there's a point I want to raise later in the webcast, but it really is a function of whether the institution has the ability to fundamentally clinically manage populations outside of their own clinical environment. Do you have the assets necessary to be an effective population manager, or do you have enough clinical integration in certain clinical areas that will allow you to function as a clinical destination player? You know, focus just on clinical bundles as opposed to the overall population.
Now you mentioned the clinical integration, so I'm going to pose the next question to you, Dr. Billingham. What does clinical integration mean? Are we talking managed care? There's different definitions, and I don't know what an integrated delivery program or integrated delivery network is as opposed to the words that are being tossed around today.
I'm not sure any of us do. It's a very good and it's a very hard question, to be honest. If this is managed care, it's managed care on steroids.
Absolutely.
I think the three of us would all agree that this time around it really does feel different for two fundamental reasons. Ron just went through how the delivery system itself has changed, but also the reimbursement has changed as well. And those two are going to be big drivers in what we're going to talk about over the next hour. Keep in mind, if you were a successful healthcare CEO in the traditional model, how did you make money or have a profitable business? You admitted patients to the hospital, you drove ancillary services, and you did more procedures. Now that's all been turned upside down. And Ron again alluded to the fact that different players are going to end up in different spots depending upon their ability and their resources to deliver that care. Not everybody's going to be capable of delivering population-based management. So I kind of think about it, we have all watched and continue to watch land grabs where people are purchasing smaller healthcare systems or large medical groups, And one of the problems with that in the delivery integrated model is what I call the hub and spoke problem, which means you may have best practices, great, guidelines, but do you know that that's happening 60 miles down the road? So just because we have consolidation doesn't necessarily mean we're going to get to continuity of the delivery of care. So in my mind, I see three different kind of venues. One is this development, lots in the press about skinny networks, which is the ability to try and control costs, control the providers, steer patients in so that you can really start to collect data and have meaningful use on that. The other is for people that can't do all that, they're forming collaboratives. And Ron, I know you and I have talked about this before, where smaller healthcare systems getting together and sharing data and helping each other out. And the last one I would call the 3 Ps. Hospitals and healthcare systems have traditionally, with clinicians, been the providers. And the game now in terms of your integrated model is, can you control the dollars and the data to deliver population-based medicine? And Ron said it well, and that's what I call the 3 Ps. No longer will it be okay to just be the provider. They also want to be the payer. They're forming their own payment systems. We're going to talk about ACOs. But at the end of the result is, can I provide excellent population-based medicine?
So I'm hearing the terms population health, integrated healthcare delivery. Is that the panacea to resolving the healthcare transformation, or just one component of it, one small component?
I think it is going to be one component. I think it will depend on, we've got kind of a dirty little secret. We do have an oversupply of beds in this country, and I'm seeing scenarios play out where as little as 2 years ago there were M&A activity that one player may have backed away from the table, and now 2 years later that entity that backed away is begging to be back at the table, and the potential buyer is looking at the demographics of that particular geography and saying, we're not really sure that a hospital even needs to be in that county. So that's going to play out across the country. Politically, as a challenge there. Hard for a governor to run on a platform that I successfully closed 25 hospitals in my state. So that's going to be a challenge. But to the tune of about 700 facilities that are going to change, either go away or are going to become ambulatory surgery centers or some other alternative care, lower care environment. So I think it all depends on whether, the recurring theme for me is, does the system have the DNA within it to be an effective population manager, or are they going to default to being clinically specific and embrace the bundles?
Now we're on to our second panelist, Kim Pardini-Kiley.
Great.
Kim, we just left off on quality metrics. We all know that quality is the name of the game in healthcare transformation, but it's not an easy thing to overcome, as we heard from both Dr. Billingham and Dr. Calhoun. Right. Can you please tell us how we can overcome those challenges?
Sure. I think, to start off, the whole idea around integration means you have to know how well you're doing in order to be able to integrate. And at a time where there's a tremendous amount of innovation going on, both on the delivery side, there's an equal amount going on the payment side, or more importantly these days, around value, right? So we're in this space now of moving from really pay for reporting to pay for performance. And this whole business of creating value is incredibly important so that we know that we're all headed in the right direction. In order to really be able to demonstrate value, you have to have good systems in place that allow you to measure outcomes, allow you to measure processes, and then you've got to be able to turn that analysis into actions that actually work across broad groups, whether that is hospitals and systems, or whether it is across a system. But in every single way, people have to start working together in order to get to the right outcomes. And there's vertical integration and there's horizontal integration when you think about quality. So when I think about vertical integration, it's that you have to be all in at the executive level, right? You really have to be able to spell out for your organization what it is that is important for you to survive and thrive in this new environment. And you have to have frontline clinical involvement. So that integration that happens vertically is very, very important. The horizontal piece is that there have to be systems to support all of that to go on, right? Because it doesn't just happen initiative after initiative. It has to be really well coordinated. So one of the things that I wanted to just kind of broach is this whole idea about, so how do you do that in an organization? How do you move beyond just measuring and reporting on quality to actually getting to the point where you're improving outcomes? Because the way that you're going to do that is going to be changing practice. And that change of practice is not an easy thing for all of us to kind of wrap our heads around. So in order to do that, you need not only to have improvement efforts going on, but you have to have a management system that supports the activities on a daily basis. And that's one of the things that is pointed out on this slide. A really good system, a good operational system, has both of those two elements. And when you start thinking about what those two elements, the first piece is that the management system has to support those activities, right? You can say, this is what we want to deliver, but if you don't have operations that support you to deliver it accurately every single time, you're not going to be able to get there. So when we think about what, you know, healthcare has been addressing, we all know we're trying to get to zero harm. We all know we're trying to improve performance around things like core measures and all of the mandatory reporting that's going on right now. So you can do it initiative by initiative, but that management system is really important. On the improvement side of the house, you can use any kind of methodologies, right? You can use lean, which I think we've seen a growing desire to kind of use some of the tools that have been proven certainly effective in manufacturing, but you're going to have to do it based upon the healthcare system, so you'll have to tweak it a little bit. But that improvement side really helps drive the outcomes you want with a management system that supports it underneath.
So the operation system that you talked about, I'm just trying to analogize it. We've got the vertical leadership and the horizontal leadership, and the operating system is sort of the glue to all of that to make sure it all happens.
Exactly.
Now, when you mention an operational system, in my mind, I'm thinking something I can buy. Can you please give us an example of the operating system that you're referring to specifically?
So an operating system is really the context, or it is the description of how you do your work. So when I think about an operating system, the elements, I mean, you really do need to define who does what and how do they do it. So really coming up with things like standard processes. You know, that's part of minimizing variation in practice, is really being very clear what you expect to happen. And then being able to monitor and measure against that to make sure that, in fact, people are doing the right things at the right time. And if they're not, why aren't they? Because when you really get to the front line and you ask those questions, you come up with a lot of ideas and a lot of answers that you can really then iterate on your processes to improve performance.
And this question's open to Ron. Ron, you have a lot of different clients. Have you seen a lot of the clients within the ACO structure and non-ACO structure actually implementing operating systems to make sure that they have these systems in place to overcome the whole quality challenge?
That's a very good question, and unfortunately that has not been consistent. And I would say that probably a majority of the ACOs that are operating right now are not fully clinically integrated. And we could probably go around the table and have, if you were to ask us to define clinical integration, we probably would have dramatically different answers, but I think they'd be converging circles. I see a lot of attention to organizational structure, to leadership. What I see missing is that dirty, grimy work of narrowing physician practice pattern variation. And that takes a unique combination of non-clinical and clinical leadership to accomplish. And I think that's the next phase that we're going into. We've kind of done some, you know, the heavy lifting as it relates to the organizational design, you know, the appropriate blend of physician and non-physician leadership. Now we're getting to the point where we really have to take variation out of the equation. One of the fundamental problems actually is the fact that about 73% of all of our platforms across the country are still fundamentally on a fee-for-service model. Although we are making, you know, the velocity of change as it relates to payment transformation is pretty great. But when you think about clinically integrating in the face of that dynamic, you're taking unnecessary utilization out of the system, you're still on a fee-for-service platform, and you're doing that against your own self-interest. because your revenue is going to reflect that. So that's another fundamental, I think, unspoken barrier to kind of breaking through the next layer of
Yeah,
clinical integration.
it's hard to do all of the clinical integration and the innovation on just the delivery side.
Right.
There has to be the equal match around the reimbursement side if we're ever
Absolutely.
going to get it together. And those two coming together is hopefully going to be the sweet spot where we can come up with, and albeit a variety of models, but clearly defined models that we don't
absolutely.
currently have.
That coordination is so important,
Yeah.
yet people just can't get their arms around it. So
Yeah.
I'm glad that you provided some helpful advice to our audience today. I'm picking up on Ron's comments regarding physicians and other leadership not getting their hands dirty. As a physician yourself and a physician leader, what's your perspective when it comes down to the leadership of healthcare organizations today? Because we all know it's the leadership that needs to move the needle, yet at the same time, Kim made a comment that frontline leadership is also equally important.
Again, a great question, and I think what both my colleagues were alluding to is that the traditional medical decision-making platform and hierarchy is getting completely disrupted as part of this change. How do you narrow behavior either organizationally or clinically? Well, in the old days, fear and money seemed to be
Pretty effective.
Pretty effective. But I think that's gone, and other traditional methodologies. For example, in large healthcare systems, for example, a friend of mine calls it bog sat LGW. Bunch of guys sitting at a table, loudest guy wins.
Yeah.
And I think that those methodologies
Yeah.
are gone, and you are going to have true integration means that everybody's going to have a seat at the table. So the way I see this is that if you're the CEO of the organization, your job is to articulate a vision that people can get behind and create an environment that lets frontline innovation succeed.
Yeah.
Because the people that are actually, it's that, you mentioned lean, but it's the ability to stop the assembly line of healthcare when somebody has a great idea on the front. And those organizations that can implement that change and do it well, they will be successful. If you're hanging on to those silos of the past, I think we're going to see flattening both vertically and horizontally. Let me give you an example. And also how we can learn from other industry. Quick healthcare example. A friend of mine is the VPMA of a large healthcare system, was sitting in a room with 10 other physicians, and they were in the process of credentialing a lot of PAs that were coming into the system. And midway through it, he realized that we didn't, as physicians, we weren't aware of the training, we didn't understand, some of the scope of practice issues, we didn't understand, some of the technical components, and he suddenly thought, well, why isn't there a PA or an NP, which are going to be 50% of the workforce going forward, having a seat at the table so we can truly integrate and learn? And that's exactly what they did. So he changed the paradigm, put them at the table, and the physicians learned a tremendous amount, and also established both transparency and a collaborative workforce. And I think it's not lost on anybody that in the Silicon Valley, the 50 miles that surround where we're sitting right now, a lot of hospital CEOs are not sitting in private, closed offices with the door shut. They're sitting out amongst their workforce, and the best ones are listening.
Yeah.
May I tag on to that?
Absolutely.
Yep, I don't want to take us off course, but I'm reminded of an experience that we had in, names removed, in a Midwestern state, large employer, high concentration of employees. And we asked the question, when was the last time that the primary integrated delivery system that these employees are being steered to through their plan design, when was the last time they met with them? And their answer was, we've never met with them. And we met with that integrated delivery system and asked the CEO the question, when was the last time you met with this employer? 7,000 lives being steered into your facility that never met. There's another fundamental problem, is this disengagement from the recognition of who the customer is, because of the historical just kind of acquiescing of that responsibility to the payer. And that's going to fundamentally change as well.
That's interesting, because you would think that the paradigm shift would actually rechange the focus of the culture, of the way that physicians, I'm using them as an example, would change, and they're just not doing that. So can we talk a little bit about how we can find a sweet spot for culture, leadership culture?
Yeah, when you think about it, exactly what Dr. Billingham described that is required of the CEO. So it's really, we're now asking a CEO to provide leadership internally to allow clinical integration to occur and to engage with a new customer that they historically, as a rule, have not really been engaged with. So that really is a totally new dynamic in terms of the leadership skills of the CEO.
And it's not something that was taught. I mean, coming up through the clinical process, we were always pegged and put out front as captains of the ship.
Right.
We weren't taught team-based training.
Right.
And so I think the younger physicians coming out will be far more geared to that, and the rest of us are adopting to this change.
Right. Yeah, although that will have to be very purposeful, right? Because even now, training in medical school doesn't necessarily focus as much as it should on teamwork, and it doesn't in some of the other disciplines as well. So we're talking about nurses and respiratory therapists, and so if you think about clinical integration, really that key and some of the sweet spot is teaching them to function as a team and how to communicate as a team. And many of our systems don't necessarily allow them to be able to communicate in real time so that they can be more effective. But I think to your point about, you know, the importance of clinician-led improvement and clinician-led processes is what is critical. It's not going to happen in a committee. A quality committee is not where things are going to change. It's going to be getting out there and really asking for that frontline input so that you can really design your models to be able to support the best outcomes.
Since we're on team-based training, Kim, in your experience, you were the Vice President of Quality and Effectiveness.
Yeah.
Can you share some of the success stories with respect to either cultural change or team-based training?
Sure. So, you know, one of the things that we did that was just phenomenally successful was what we called in situ simulation. And in situ simulation, in situ, some people say as well, is really about teaching people to be functional members of a team in their environment, which is different than taking people off site and going to a simulation center. So we found that when we actually, you know, held a patient room and did simulations in the room, you know, on the units where everybody practices, and pulled people into it, and then went through a scenario and then debriefed at the end, the learnings were tremendous. And everybody's perspective was brought forward that they didn't normally do. So after an event happens, everybody goes their merry way, and this really allows people to learn on the, you know, in the real world about how do you more effectively communicate. And I do think that teamwork is going to be key for us because it is such a complex environment.
Dr. Billingham, what kind of work have you seen with respect to team-based training?
Well, more and more. I mean, obviously, even though there's such a grind to get through the medical school process, we are taking the time to teach, particularly the young physicians and residents. So things like sign-offs, things like a handoff process, particularly, you know, at the end of shift, where there's more communication, and everybody is empowered to speak up. And disrupting what may have been, you know, traditional communication processes in the past. We're going to flatten the hierarchy. It is too complex not to do that, and particularly when you talk about not only achieving efficiencies but also patient safety initiatives. Everybody's got to be empowered to say, "Oh, stop! Can we take a look at this again?" And I think that's happening, but this is going to take time. This is not going to happen. It's change in healthcare is hard on everybody, and it's going to take some time.
Do you see a, we all see a lot about evidence-based, and the reality is, in the Medicare population alone, evidence-based medicine is practiced about 9% of the time. So do you see the team-based efforts being a vehicle to, we hear much less about clinical best practices and a lot more about clinical integration. And so these clinical best practices are not evidence-based, obviously, but should be equally as embraced. But do you think that evidence-based gets more press than it should, in almost to the exclusion of getting more clinical best practices established?
Well, I think what we struggle with is that there's not always good evidence for many of the things that we do. So, I mean, we really struggle with, you know, how accurate is the evidence and what can we base some of our practices on? And at the same time, you know, there's so many nuances in the practice of, you know, medicine. Not only for physicians, but for nurses as well, which is about a communication with the patient and kind of evaluating that. So I think evidence needs to continue to inform us and to set the standards where we have it. And I think the other piece is that we have to be nimble when it comes to evidence, because evidence is also changing, you know, very rapidly. And so we don't want to, you know, put in a practice that, you know, then changes and not allow that change to happen. So that nimbleness, I think, is critical.
Yeah, I want to just follow up on that and say, you know, there are campaigns and efforts to do, Ron, exactly what you said, which is to not only make best practices or evidence-based guidelines, but also in a most cost-effective platform as well. Campaigns like Choosing Wisely. Well, there's a big discussion going on right now because of so much of the cost on defensive practice and defensive medicine in the United States, which is understand that this is evidence-based literature and that this is the smart thing to do. Understand that this is the least expensive and most cost-effective. But we didn't really have the discussion about it. If you do that, did it come with safe harbors or some sort of tort protection? So I think that's one of the barriers to rapid adoption, how you change people's behavior, which is if we do use these clinical practices and there is a bad outcome, will there be some tort relief?
Right.
That's the downside. I'm going to try and keep it light and on the upside. But thank you very much, Dr. Billing. I do want to swing back to you, Kim. You talked about public reporting, and we know that public reporting is getting bigger and there's more regulation. So I just would like for the audience to understand how public reporting is actually going to increase quality of care.
Well, let's face it. Now that we're into the pay-for-performance world, you really have an obligation to continually improve. So the public reporting has really made visible the things that providers and healthcare systems should be providing in terms of delivery. It's that nimbleness that I talked about that I think is a little bit of the Achilles heel. Are we always measuring the right things? But to be honest, firm belief that this move towards public reporting has been in large part a really good thing for improving patient care.
I'm going to take a little detour with public reporting, and I'd like all of your opinion on this. Transparency in healthcare is huge. We have transparency in healthcare with respect to disclosing medical errors, and now we're going to transparency with respect to quality metrics as well as pricing. So is a sweet spot an opportunity to perhaps take this transparency reporting and focus it on a particular group? So I'm going to use the young folks. The young folks are highly wired in. They're spending their money in certain ways, and they want to keep and protect their money, and they're easily able to potentially in the future download certain apps that are going to display quality metrics, pricing, a variety of physicians and services around the country. I'm going to start with our physician expert first, and wanted to get your thoughts on that as a strategy for some organizations.
Well, I think in terms of the ability for delivering care that's cost effective, we're all going to have to get a lot better educated on those choices. And I would translate what you just said as sometimes I get pushed back into, gee, Graham, don't talk to me about cookbook medicine, because medicine, in fact, is an art and a science. And it is, and what I would say is that's great for these 90 chief complaints, but for these 10, maybe we could sit at a table and have some consensus on and structure the delivery of it to ensure that we have the best data, we have the best guidelines, and that we narrow practice variation for potentially high-risk diagnoses.
I would like to add to that with a bit of a twist. If you were to kind of visualize an axis that varies by low acuity to high acuity, and then another axis, and that's a horizontal axis, and then a vertical axis that varies by anonymity and an intimate relationship with the patient. This lower, I'm reversing here, this lower left quadrant anonymous, low acuity, is there's major transformation going on in that basic care box. And it's a box that acute care has not really done a very good job reaching out into that. Acute care is in that upper right, where you've got higher levels of acuity and an intimate relationship with the patients. The lower right is the ER, basically, higher levels of acuity, anonymity. So I think a big challenge is going to be how is acute care, particularly in the context of population management, going to effectively reach into that lower acuity anonymous box. And I think that there's a lot, because that box actually populates out to be bigger than the other three combined. And you've got a lot of disruptive models that are emerging out there that are very effectively attaching into that box. What made me think about that was your description of the younger demographic that are used to consuming things differently. And I think that is a major transformation external to the four walls of the acute care facility that needs to occur, that quite frankly, we're not seeing a lot of. They're outliers. Geisinger does a fabulous job. Spectrum Health with their community outreach program, Banner with their MedSeek patient engagement strategy. But engaging a patient before they actually become a high acuity patient is going to be critical in population management, and that is an area that I think needs a lot of work.
So maybe I could swing through to follow up on Ron's point, talk a little bit, because I think the word that I would use to capture what you just said is access.
Absolutely.
And I think we've got some huge drivers, and we've got some math problems. So maybe I'd spend a minute and just talk about those.
Sure.
Yeah, you've got a great slide on that.
Okay. So I think one of the things is there's a tremendous amount of uncertainty in healthcare. We can all agree on that. Hospital CEOs are trying to not only get fiscal house but physician alignment. One of the mistakes I would say is that physician employment doesn't equal alignment,
right.
And you really got to back to everything we've been talking about, which is everybody having a voice in the table. So here's the math problem I was alluding to. We talked a little bit about defensive medicine and costs. Every day now in the paper you're reading about the lack of or the ability to deliver mental health services. We have huge number of people that need these critical services but not enough beds. Our primary care deliverers, we've talked about nurse practitioners and PAs being huge component, important part of that workforce going forward. But we're still at ratios where to deliver on the acute care side, we're still shortfalls.
Right.
What Ron was talking about was, we have 30 to 40 million new people coming in the system, 75 million boomers that are complex, they take multiple medications, require a lot of follow-up. And they are seeking access elsewhere.
That's
and
right.
When we come back and we end and we talk about innovation, that's where a lot of the innovation and where we can learn from other industries. One of my personal things, just from a risk thing, is we are trying to incentivize people not to admit, not to readmit, to order less tests. I think this is going to be difficult to do in the boomer population because of the comorbidity and mortality. We're going to have to figure out for that population better ways to take care of them. And we've talked about this already, the hub and spoke problem about if you do get these healthcare systems or practices in, how do you make sure you have consistency? To your point, communication. Will my electronic healthcare record talk to their electronic? And the bottom line is, these things take time. It takes, we're talking about integrating healthcare systems is not going to happen overnight. So one piece of advice I would say was take a deep breath. We have a common saying in the emergency department, when there's an emergency, the first pulse you take is your own. So everybody take a deep breath. And I am a glasses half full, but there are a few winners that have nailed this, and what can we learn from them? These are some of the emerging risks, sort of where the puck is going. I think some of these new technologies you talked about, are we going to see new standards of care in healthcare delivery? Will we be held accountable for not using the latest and greatest technology? Drug shortages. How are we going to make do that the drugs that we traditionally used to take care of people are not necessarily available? What is it that's going to take leadership? And I would go back to, we are stewards of this process. And the right healthcare leaders are going to look at other industries and they're going to realize that if I could articulate a vision that everybody could get behind, and I ensure good communication, but I empower people to have disruptive technology and bring it in. Telemedicine.
Absolutely.
So, telemedicine, the estimates are 30% of healthcare delivery. To Ron's point about access.
Yep, absolutely.
So we're going to need to figure out innovative ways to increase access, and the public's going to drive it.
Yep.
I'm glad that you ended on innovation, because I actually want to move on to innovation. Innovation, experimentation, nimbleness, disruption. Those are the words, those are the buzzwords that I'm hearing regarding healthcare transformation today. It's a challenge because healthcare organizations are facing financial constraints, and it's kind of hard to be innovative when there's increasing regulation. So I want to start with Ron. What does it mean to be innovative and disruptive in healthcare? What does that look like?
Well, first it requires in my opinion, a high level of self-awareness, and know what you're good at and what you're not good at. And so when to Graham's earlier slide, in trying to estimate where the puck is going, are you going to be a population health manager, or are you going to be a clinical destination? And that kind of dictates which path you're going down. Once you understand the path you're going down, probably the best thing I could say is be very open to innovative ways to engage with the patient on the front end and on the post-acute side. Now, one issue, just very quickly about post-acute, I think I don't want to leave without referencing the post-acute world that we have right now. It's under the stressors that are very similar to what Graham just alluded to. If you just look at the dementia population now, 12.5 million seniors with one of the 47 forms of dementia. And we only have, if you add skilled nursing, assisted living, LTACs, STACs, and et al., it roughly foots to about 4.6, 4.7 million total post-acute beds. Well, 30% of that 12.5 million population of dementia patients need to be facilitated, about 40% need to be supervised. We're woefully inadequate in our post-acute infrastructure just to deal with the dementia population. We're not even talking about the top 15 chronic conditions. So we've got as we're asking acute care to drive higher levels of acuity into lower level care settings, we have some vulnerabilities on the post-acute infrastructure front too. So all that to say, I think we need to really, a chief medical officer of a client of ours said it best. He said, Ron, the music industry's been through it, major transformation. Their fundamental revenue models changed. The publishing business has fundamentally changed. It's just our turn. It's just our turn. So I would argue that whether you're a population manager or a clinical destination, you need to be very open to alternative ways of reaching out and identifying the patient, the member, and pulling them into the system and discharging them, because there'll be very, very disruptive models on both sides of that will be emerging.
By pulling them into the system, I've actually seen Walgreens do it already,
Absolutely.
Not even with patients alone. If you go ahead and submit your tracking data, they'll go ahead and give you a couple dollars off of your soda pop or off of your medication.
Absolutely.
So I see what you're talking about with respect to innovation. Now, Kim, you had mentioned nimbleness earlier. That is quite the challenge, knowing that evidence-based practices are going to be changing, and that payment models are going to be changing. Please give us your insight on how do we become nimble? Do we go back to the operating system to plug in the ability to move and flex and stretch and bend?
I think the engagement of physicians and the physician specialty societies will be probably the leaders in terms of that nimbleness. In the past, there had been, the definition of what outcomes we needed to look at that were done, CMS, Joint Commission, high level. We're really bringing that down, so each of the societies are saying these are the things that we need to pay attention to. And when they become more nimble by kind of putting a stake in the ground, I think we'll be able to achieve better outcomes.
I completely agree.
Basically, what I'm hearing from this conversation is that there's 1,000 ways to skin a cat, that healthcare transformation isn't going to resolve on its own without a variety of different strategies and methodologies, is what I'm hearing. But one area of opportunity that you mentioned earlier, which Ron earlier reinforced, is the fact that there's a lack of standard operating systems. I do want to go back to innovation one more time. One story that I recall is a story, I'm going to have to come back to Silicon Valley here, is the story of PayPal. PayPal actually started off or was envisioned as an encryption service. And after starting the business model, they had to fall down a couple of times, and now today they are the big default payment system. So what I'm hearing from the panel today, or from Ron's comments, is that leaders need to be self-aware and need to step out of the box and be willing to try and take risk. Is that what I'm hearing as far as innovation?
I think so. It's a hard thing to do in a healthcare delivery system. I think we get trapped in trying to put out the fire of the day. And I think what you're alluding to is we need to change our mentality. And the organizations that are nimble, that can drive innovation and give a platform to execute it. Because I think we could all sit in a room and have great ideas on some of these challenges, but executing them, particularly across a population, that's going to take some time. And so one thing I would add to that is start to think in terms of developing countermeasures, not just solutions, because they're going to be a wave of new technologies, new problems. So can you as leaders develop a way to think and react that allows you to turn the Titanic? Because some of these institutions can you turn the Titanic? And the way I would look at it is not everything is applicable across the platform of healthcare. So I would use the ivory towers example. There's some shining examples of healthcare systems that are doing it from soup to nuts really well. But you may not have the resources, you may not have the infrastructure, the IT to do it. So grab the parts you can and adapt them and adopt them in order to drive innovation in your own healthcare system.
So I want to ask him a little bit about that. Dr. Billingham made a comment regarding building that into your processes again, the ability to adapt. Can we talk a little bit about that within the quality realm?
Sure. I mean, the ability to adapt
and innovate in the quality realm.
Innovate in the same space takes, effort. And you have to be very specific about those efforts. So the whole idea about how do you embrace innovation is not just coming up with a grand idea and implementing it, it's really being very purposeful about what are the types of things that you want to be able to innovate on. And one of the things I would like to point out is that we're seeing a lot of emerging markets around innovation in healthcare that have not happened before. Really exciting stuff. There's an innovation conference now, Mayo Clinic sponsors, Medicine X at Stanford, another great, vehicle. And I think we're going to start to see more and more outside groups looking at how they can innovate in the healthcare space. What we need to be able to do is to be open to that and to be able, actually willing participants to trial some of those innovations. So I think that, we'll look at emerging technologies to help us innovate. And then the other piece is back to the frontline clinicians, is really around communication and engagement for them. And if you can innovate on the technology side and you can innovate in how people work together, then I think those two things coming together is where hospitals and health systems are going to end up being more successful.
Okay, so
completely agree. Yeah, and a lot of that is bottom up, like you said. A lot of those innovations are out in the field. We have a client that struggles with a midwife scenario in a rural part of the state, and it was through a series of dialogue. We actually, Dr. Henry Lerner is developing shoulder dysplasia in partnership with Google Glass. So the midwife can keep her hands on the patient, never leave the patient, and have the video walk her through how to deal with a shoulder dysplasia issue. That was a kind of a ground up, and the institution's trying to rapidly adopt that without, getting hung up on the evidence-based piece of it. So therein lies the challenge. It's a real issue. It's a real issue. And I would just ask the audience to take this in the spirit which it's intended. Owning more assets on the ambulatory side and the primary care side or the post-acute side does not necessarily make you an integrated system. It gives you the ability, just like dealing with those organizational issues, dealing with those leadership issues. It gives you the ability, but grinding through narrowing that variation is a whole nother game.
Any comments?
I completely agree. And we're going to have to solve technology issues, communication issues, and again, I think we've said it. It's probably worth saying again. Is just because you have coverage doesn't mean there's access out there. Just because you have consolidation doesn't mean that you have continuity. And just because you have employment, that doesn't mean there's alignment. So I think there's some fundamental
really good point.
Themes that are happening out there in the healthcare world, and I think this takes 6 to 10 years to sort through. It's not going to happen overnight. Look around within your own institution. There is a cost to sitting still. I wouldn't advise anybody to sit still. This train is moving, but at the same time, pick and choose. Don't put your head in the sand, and start somewhere. And start somewhere with a consistent process that empowers people to have a voice, and then prioritize those things that are going to drive efficiency and better care and improve quality, while you're keeping your eyes on the cost dial. And if you want the clinicians, the physicians, I'll wear my physician hat at the table. Be transparent with us. Give us all the data. Let us be part of the data. Give us a seat at the table. I mean, I've heard it said many times, we're both part of the problem and part of the solution. And we have the power of the pen in the sense that we're ordering all these, tests and stuff. So I think getting the clinicians on board, we're trained to be skeptical of data. And so we'll ask hard questions, but I think if we have good data and we have a seat at the table, we can be part of the solution.
We're now to our open question and answer, and we have a question that I'll address to Kim. One of our audience members asked, do you see risk and quality taking on more active roles on the revenue side of healthcare? If so, and how?
And the answer is yes. And because doing the right thing, doing it well, ultimately will impact your revenue. So a model in which doesn't separate those things out, I think, is a more efficient model. Finance working on reducing costs in its own world and in a vacuum, and quality working on outcomes, and risk working on, managing events and reducing risk is not a sustainable model. You have to bring people together, and they have to understand the impact of what they're doing and what they're proposing needs to get done in terms of clinical care, the delivery, the management of all of that. So I really think that having a mind to cost, quality, and service as really that mantra around value, reducing waste, is then really where we're going to end up, I think, making a more significant impact.
Thank you for those comments, because quality and risk often are siloed, and in some other hospitals that are working together, but their missions are actually different between patient safety and quality. This question is for Ron. One audience member is asking, how are captive insurance companies adapting to emerging trends in healthcare delivery?
And how much time do I have? I think we have a minute and a half. Wow. I would say it could be broken into a couple different categories. One is how to more efficiently cover things like cyber liability, particularly as we move into stage 3 meaningful use, which completely fundamentally changes the cyber liability landscape. Regulatory risk, Medicare, Medicaid fraud and abuse. The risk factors associated with that particular risk are not intuitive. They're not the same as a lot of underwriters are looking at RAC auditors and MIP auditors, and they're going after different things. So there's still a lot of that's an immature environment that I think a lot of big systems are looking at their captives to fund. And they're also preparing to fund more efficiently for provider stop-loss vehicles to actually provide financial protection in some of these risk-bearing arrangements, whether they're clinical bundles, global bundles, et cetera. Lastly would be a good vehicle to, we're talking to several clients about their contemplation of creating warranties around these clinical bundles. So I think that will grow in interest, and we're actually working with some right now on that front.
A lot of challenges. Thank you, Ron. It looks like we come to the conclusion of our 1 hour section. As you are all aware, we are going to continue this lively panel discussion. I would like to thank our panelists right now because this topic is very much a doom and gloom topic. And I'd like to thank the panelists for keeping the optimism and enthusiasm for the future, because there really are ways that healthcare organizations can thrive within healthcare change. Now, before we conclude, I'd like to go around the table, starting with Dr. Billingham, and ask each panelist to give one takeaway. Specifically, where do you all see the greatest opportunity?
Well, I think we're all striving for efficiency in a healthcare system that really wants to get there. There's a lot of conversations about the economics. There's a lot of conversations about productivity. I guess my parting shot was, when you're engaging in those, don't start with the money dialogue. Start by putting the patient first and let everything else follow behind that. So I think healthcare is about the patient, so while we're in the process of ferreting through all these challenges, look for the opportunities that improve patient care.
Ron?
I would say probably variations on the same thing. Be open to alternative ways of engaging with that basic care box that I was referring to, that lower acuity, anonymous, consumer-centric population that acute care providers are just not genetically predisposed to marketing to. That landscape will change dramatically. Be open to new ways of accessing those populations. And one other quick point that hasn't actually been mentioned today, and that is, and we see this among very sophisticated providers, and this is it's kind of a random point, but it's an important one. You have to fundamentally understand your cost of care. And there is a lot of ambiguity around exactly what the cost of care is. It's not the charge master. There's a variety of sophisticated ways of assessing your cost of care, but there's a lot of sophisticated providers that don't understand their cost of care. You've got to understand your cost of care.
Agree with that. And Kim?
Don't be afraid to start small. Take it step by step. I think we all wait for the grand scheme. We all wait for the perfect solution, and just don't be afraid to identify your problems and start small.
Well, thank you, panelists. Our 1 hour has come to a conclusion. However, we will continue our live panel discussion. I'd like to thank our partners, Aon Risk Solutions and the Medical Protective Company, for today's presentation. Thank you.
Thank you.
So we do have additional questions from the audience. I actually want to hear your take on the question that Kim answered earlier too, about risk and quality from the physician perspective, having a stake at the table in improving revenue, because oftentimes the lonely risk manager doesn't feel that they're empowered to make an impact on the revenue side, that they're just constantly being reactionary.
Well, I think it's going to be part of the payment structure going forward. I mean, it's as simple as that, is that these quality measures that Kim talked about are going to be embedded, and that, you know, a lot of healthcare systems have a really thin margin, so getting the clinical folks on board to not only accurately measure the ability to have a feedback loop, so you get all this data, what do you do with it? I think the issue really is going to be, it's a given that it's going to be part of additional, whether it's pay for performance or, you know, beyond. So I think quality and the avoidance of risk in terms of decreasing loss costs for healthcare institutions. So both patient safety, quality, they've got a seat at the table, and organizations that pay attention to those will definitely increase their revenue.
And I'd like to hear your perspective from the 35,000-foot level regarding risk and quality and your experience from what you've seen.
Yeah, I'm going to take my answer in a bit of a different direction, and it doesn't completely address your question, but it's in the same neighborhood, different block. I would challenge the risk management function within the acute care provider community across the country to be aware of new emerging risks that have operational and financial consequences to them as it relates to these payment transformation models and as it relates to reform in general. I think probably the most missed, yet one of the most significant risks around Medicaid expansion and the expansion of coverage in general is credit risk. It's taking a $60,000, $50,000 employee or family of four who's never had coverage, and they buy a lower metal plan, a bronze plan, and now they have coverage, but they have a $12,000 to $15,000 total out of pocket. What we've kind of, there's a piece of coverage expansion that transitions credit risk to our clients. And many of these clients are participating in, payment plans and whatnot that, and they've drifted into basically the consumer credit world, which has about 12 different statutes that regulates that. And many of them are out of compliance with a lot of those statutes. So that's just one of those unintended consequences of a well-intending, strategy to hopefully increase the wallet size of the consumers. Particularly, there's another hidden risk in this dynamic, and that is within those states that are not accepting Medicaid expansion. So you've got a drawdown in the disproportionate share formula. It can be earned back based on the number of patients that you transition, or the number of citizens in that state that you transition from uninsured to insured. You can earn that disproportionate share back. If you're in a non-Medicaid expansion state, you don't have that ability because you're not transitioning enough bodies. You don't have a vehicle to transition those bodies. So particularly in the states that are not, up to 23 now, that are not accepting the Medicaid expansion, there's some significant financial risk there for the provider community. So there are, in these payment transformation models, there are embedded risks that are not necessarily intuitive.
Can I piggyback on Ron's and change the paradigm a little bit? And I think we're talking about two different things, AR and ERM. And AR, he is exactly right. So you suddenly now, with these high deductible plans, suddenly put medical groups and hospitals in the collection business.
Absolutely.
So now if you have I'll just throw a question out. So now if you have a bad outcome, are you sending grandpa to collections? And that's not only this credit risk, but it's suddenly understanding people suddenly feel they haven't gone to the doctor for a long time. They do have coverage. They may not fully understand the ramifications of that coverage, and then they get an $800 bill after going to the ER, and they're unhappy. And so I think we've got a ways to go. And I would say that you raised RAC audits, HIPAA, security. I would say that the traditional kernel of clinical risk management, CRM, which is always going to be the kernel, is going to have a layer of ERM, or enterprise risk management. And we, as healthcare, leaders and advisors, we have to have conversations not only about the quality of care, the measurement of data, but we need to understand regulatory compliance.
Absolutely.
We need to understand this financial shift in accounts receivable, all of those. So it's financial risk, legal risk, regulatory risk, and clinical risk.
It seems, oh, go ahead.
And operational risk if you don't know your cost of care. I mean, it literally covers all four quadrants. You're right.
I'm going to ask you, Dr. Graham, Dr. Billingham, it seems that we need a little bit more better choreography and coordination with risk management and the activities that are currently going on. Are you currently seeing mergers and acquisitions happen with risk management involvement ahead of time? Or is risk management functioning in a reactionary mode?
I think it's better than it's ever been. We have a ways to go. But I think the chief risk officers of institutions are going to have a seat on the senior management team, and they're going to identify things, and I think the smart C-suites are going to put those risk people to have those conversations. Ron talked about the land grab that's going on, and we've been talking about physician employment and consolidation, and 37% of the audience talking about M&A. I will tell you that when I've spoken to different leadership, I was surprised at the lack of due diligence that was taking place in some of those land grabs, where people were actually going out because the competitor down the street was doing it and saying, boy, if I don't do this, I'm going to do it. So I think it's essential to have the risk people involved early and have a seat at the table.
Thank you. We have 3 experts at our table, so now is really the opportunity for each of you to ask a burning question that you've been wanting to know, to either hear from Ron or Dr. Billingham or Kim.
I actually have one that I've been waiting to ask him, and that is, it's having conversations with our clients about the sheer volume of quality measures that they have to keep track of. We have clients that are participating in the Medicare Shared Savings Program, the Bundle Payment for Care Improvement Initiative, the Value-Based Reimbursement Program, and let's throw in the Collaborative Care ACO from Cigna, and then Aetna's ACO model. They could have 150 quality measures that they're trying to track.
Easy.
And do you see a movement? I'm having some interesting conversations with some clinicians about this, but I'm just curious to know what Stanford's view is as it relates to an effort to coalesce some of these quality measures into really meaningful core quality measures that will move the needle the most.
I think it will continue to explode before that happens, because each of the various measures are being driven by different fractions, right? So we've got ambulatory, that most hospitals now are also in the ambulatory business, so they've got to focus on that. We've got inpatient indicators. And as all the specialties become more involved, they're looking at additional, data and information. So
chronic condition quality measures for the Medicare population.
We're starting to see some alignment. So if you look at, especially on the ambulatory side, meaningful use, PQRS, you can actually, but it takes a lot of time, sort through all of those, and you can come up with a core set that will, but that takes time and effort.
And a level of sophistication.
Indeed, and we had people dedicated to actually look into that so that we would minimize the burden of some of the data collection that happens. The other piece that's got to happen is the ability to use our electronic records more effectively to help us on the front end of collecting some of those data. It won't circumvent the need for validation on kind of the back end, but the more that you can align and automate, the better off we're going to be. So,
this is kind of an unfair question, follow-up question, but do you see most EMR platforms being willing to accept workarounds as it relates to PHRs and your way that you're communicating and connecting with the consumer or with the former patient?
I think most of them were started not with none of that in their intent,
in mind,
right? So that was not even on their radar. If you look at some of the bigger groups, there isn't actually a user group specific to quality reporting. But there is one for, finance, there's one, So I do believe that it's starting to happen, but now we're trying to make that happen on the back end. So, and hence the explosion of looking at registries, clinical registries, so that are actually, submitting direct to the registry because your EMR doesn't have a spot for that data point to be captured. So, it's still, I don't know what the answer is. I think it's a work in progress. I think we're going to see more connection from EMRs into registries because it does allow for more longitudinal data collection. And when that, as that continues, I think we'll be a little bit in a better position to automate.
But it does seem like that there's a bit of catch-up right now, particularly as it relates to stage 3.
Without a doubt.
There's a bit of catch-up on those
Without
functionalities.
a doubt, yep.
I have a question for both of you. If you were sitting and listening to this discussion, but you weren't in the cities and you weren't in the suburbs, and you had a 25-bed hospital bed, but you were responsible for a large catchment area and providing care. What are the takeaways that help me navigate if I don't have huge resources, I don't have an IT infrastructure, I'm still trying to implement my electronic healthcare record, and furthermore, I can't get specialty providers? What are some of the solutions for
help?
If you don't mind, I'll go
ahead. No, go ahead. I'll see where that takes us.
That's a tough one. It
is hard.
Two quick points. One, Most systems, it's kind of an interesting phenomenon. Most systems are utilization's flat. If they have not embarked on a really serious journey for clinical integration, utilization's flat, but it's spiking in the hub and dropping in the feeders because they're pulling utilization out from the feeders. There are a few exceptions, a few very sophisticated exceptions where they've actually reversed that and are driving utilization out to
pushing
the feeders.
it out.
Yeah. So it really depends on your tertiary care relationships and what it varies by market. But that's critical. What kind of because we've seen some well, actually I'm segueing into my second point, and that is the very sophisticated telemedicine models right now.
Yep.
That are, so for example, in rural America, I don't think I'm saying anything that's too politically incorrect here, most of our on-call scenarios across the country in rural America are just fundamentally broke. They're broke. Hard to get coverage, hard to get a neurologist to cover 3 rural counties. But we have very sophisticated ways to beam in that neurologist and keep a hospitalist from unnecessarily transferring the patient to that tertiary care facility. I can do a complete neurological exam, or at least 95% of one. I'm not out of my comfort zone. Okay, I don't have to transfer the patient. So we're seeing some pretty sophisticated ways of keeping utilization in those rural environments. But ultimately, and I've had conversations with CEOs of critical access hospitals, ultimately they better be thinking about an alternative care setting kind of transition, in my opinion.
Yeah, the other thing that I would want to say to that 25-bed hospital is back to my point around the need to have a good management system in place. I mean, even in a place like Stanford, where we have, resources, at our beck and call, we had started with, we owned it as a quality department, collecting all of that information, and we said this is not going to be sustainable in the long run. So it's pushing it out again back to the front line. How do you engage them so that they all become active participants in driving, really the outcomes that you want, and in terms of being able to kind of put some systems where you can collect the data. So that's what I would say, is that you have to look at your operations and you can't just layer it in. It has to become a part of it.
But if they're not affiliated,
right?
If they're an independent
it's going to be
and
tougher.
don't have that ability, that's tough.
And that's what I think is driving a lot of the growth in collaboratives,
Yeah.
where 15 or 10 or 20 can share resources, share education, share data. It's tough. It's going to be tough to do this by yourself.
Yeah.
Vanderbilt's doing a wonderful job of doing that in Tennessee right now, reaching out to the rural facilities, and they're actually pushing utilization out. That's a really interesting model where it's kind of the opposite of of the trend that we're seeing. But it's a challenge. It's a challenge. It's a challenge. And once again, it's a situation that requires the financial metric to be in line with that strategy. And oftentimes, certainly in a fee-for-service platform, it's not. Yeah.
More questions, or Kim? Oh, I have questions then.
Okay, all right.
My question is, do you think someone in healthcare is going to change healthcare? Or is it going to be someone from Silicon Valley, who these are entrepreneurs who are looking at the current system and saying, I'm an engineer. I'm sure I could assemble all those fragmented pieces together.
Somebody else go first.
Well,
I actually have something to say, but
I've heard the analogy before, well, gee, if McDonald's can get queuing right, why can't we in healthcare system? And so I think there's some really bright folks that have a way of thinking that looks at, regardless of what the challenge is, healthcare or not, and maybe they're unencumbered by tradition and history and able to jump from point A to point B much more nimbly, is the word I guess we've been using. So I think it'll be a combination, really. It'll be somebody who's taking a look from the outside in, but they're going to want to have conversations with the people who are actually delivering the service to vet it.
Yeah, they have to be part of the team. But it really will take a team approach for this. And let's not forget that I think the patient will play an increasingly important role in that design. So as we figure out how to coach patients to manage their wellness or to manage their illness, they're going to be part of the conversation. So
you touched on a really great topic, which is getting patients engaged. So as we mentioned earlier, Walgreens is getting their patients engaged. How are hospitals currently right now getting their patients engaged?
I'll jump in here because I want to make the point that I ceded to Graham. As a rule, not very well. As a rule, not very well. But there are a lot of exceptions to that. But I get back to my earlier analogy of the two axes, and that lower acuity anonymous box, that basic care box. And in my opinion, it will be an entity outside of acute care that really cracks that code. We're starting to see that with Walgreens and CVS right now. The Walmart is going to be getting into that space in a very big way. They're dipping their toe in right now, but all signs seem to indicate that them and Target will do the same thing. I think that considering that 51% of all the ACOs are physician-led, I think that a combination of primary care assets with an innovator, a disruptor, is a very, very powerful combination. And if acute care doesn't figure out the patient engagement conundrum, they could find themselves being subcontracted to for the ER and the OR. That's my concern for our client base, is they've got to get into the patient engagement world in a big way.
And that doesn't mean just social media.
That is not social media.
It means really engaging them.
Yeah, absolutely.
It's interesting that we haven't been able to do that thus far.
Well, they haven't been incentivized to. You know, and they're the way that they've been paid, it was in pursuit of a completely different model. But when you think about it, I still go into this, I feel like a relic going into a store and buying a CD now. I mean, and that didn't take that long.
Yeah, it didn't.
I have friends that say, I can't believe you still have CDs. Yeah. So you know, there's some highly disruptive opportunities out there in healthcare.
Well, I'm looking forward to hearing about more disruption, but we've come to the close of our presentation. For those of you who stayed on the call, please use your resources tab to go ahead and submit a survey. Again, I'd like to thank the entire expert panel, Kim Pardini-Kiley, Ron Calhoun, and Dr. Graham Billingham, for joining us for this very complex topic that we can go on talking on for hours, perhaps over a glass of wine. Thank you very much for attending. And thank you to our partners, Aon Risk Solutions and the Medical Protective Company.